Good evening to all of you. From Urihk Pharma team, I would like to welcome all of you for the scientific session, sir and ma'am. As Immunomodulators has found a sweet spot in the management of critically ill patients with the COVID-19 since the pandemic has hit the entire world. Though immunomodulators are well-established class of drug in rheumatology as well as in oncology practice, but their role is in critical care illness like sepsis and pancreatitis is not well established. So before COVID-19, except for few immunomodulators like steroid, high-dose vitamin C, thiamine, and ulinastatin, there were not many options which were available. So, sir, to address this important aspect of immune response in critical illnesses, Urihk Pharma has taken an academic initiative and created a platform called AIMC, which is Advocacy for Immune Modulation in Critical Illness. So, under this banner of AIMC, we conduct scientific programs like this one. So, with this intro, I would like to invite our moderator of today's meeting, Dr. P.V. Palipa Gopal. Sir, Dr. Gopal has an overall experience of more than 37 years, and he's currently working as senior consultant and head in the Department of Critical Care Medicine at Continental Hospital, Hyderabad. He's trained extensively in anesthesia and critical care medicine, and he's an esteemed member of various societies. And what I feel that he does not need any introduction. He's such a he has done so much of contribution in critical care in India. So, Dr. Gopal, sir, please take the session ahead, sir.
Thank you, Ms. Bhavna, for your kind words. And to start with, I appreciate the effort being made by several pharmaceutical companies, including the Urihk Pharma, to pinpoint this opportunity in time, which is very unique. Unfortunately, we're at a time where we're fighting a pandemic, and all armamentoria that are available to humankind and medical field are being used to fight this pandemic. But as the pundits say, there is a silver lining to every dark cloud. The silver lining to this dark cloud is probably capsuled in one single word: repurposing. We are repurposing several agents, several technologies, and several techniques to fight this pandemic and save the lives of millions of people. One such technology which saw the light of the day again is the immunomodulators. As Ms. Sunita said, they are not new. They have been in the market for quite some time, and we have been using it in different shapes. I mean, from simple things like hydroxychloroquine to complicated things like MABs. We have used the armamentoria in various circumstances, and this is a golden opportunity for us to learn and capture the experience that we have seen through last 1.5 years in this situation, and repurpose the same immunomodulators and learn from each other's experience. Today is one such opportunity, and I thank Urihk Pharma for that. Today evening, the session contains two main sections. Section 1 is a couple of lecture by our bright young consultants who have got a very rich experience in this field. And section 2 is a panel discussion by another group of expert panelists, including the two speakers. And in this coming 1 to 1.5 hours, I think we'll take home several points and use them to the benefit of our own patients who put their lives in our hands. So to start with, I request Dr. Raghavendra Reddy. He's a pulmonologist. He's an MD and FCCP. He's with an IDCCM. He's a pulmonologist in Rindava Neelima Hospital in Hyderabad. He's a well-known face in Hyderabad circles and elsewhere. So I request him to take us forward in the next few minutes on immune dysregulation and therapeutic approach in sepsis and ARDS. Basically, we all know that one of the main etiopathogenesis of ARDS and sepsis is immune dysregulation. But the nitty-gritty of it, the granulation of that is something highly scientific, in which Dr. Raghavendra will enlighten us in coming few minutes. Dr. Raghavendra, your mic is mute, Dr. Raghavendra.
Thank you so much, sir. Thank you for your kind words. So without wasting any time, I would like to start off with the presentation. Yeah. So today my topic will be like immune dysregulation in sepsis and ARDS and its therapeutic approach. As we all know, critical ill patients have altered immunity. So immune dysfunction is common in critical ill, which is affecting patients' motility and mobility. And however, immune system is frequently overlooked. It may be due to the complexity of the derangement, or it may be due to any inability to assess the routine biomarkers such as C-reactive protein, procalcitonin, and numeric distributions of leukocytes. So coming to immune activity. Immune activity includes several components of immune system. The most three important includes the physical barrier with tissue invasion, innate immune response, and adaptive component. Each of these components are altered in critical ill patients, which increases the vulnerability of infection and its systemic consequences of dysfunction of defense response. Each person have different defense response, and response is different in different individuals. As we see, we have two different patients here. In patient A, where patient A undergoes a pronounced inflammatory phase characterized by increased production of tumors, TNF alpha, interleukin 1, and interleukin 12. Whereas in patient B, we see a patient B enters into the persistent phase of injury-associated immune suppression, which is characterized by increased production of cytokines, interleukin 10 and interleukin 4. Persistent immune suppression can cause viral reactivation, secondary infection, and increased mortality. Here we see there is increase in the hospital stay and increase in the time taken for the survival. Coming to the cytokine storm, I think since last 1 year from the beginning of pandemic, we are well aware of this term called as cytokine storm. So what exactly it is? So it is an interaction between the innate immune cells like neutrophils, monocytes, and dendritic cells with exogenous pathogen driver or endogenous molecules, in which innate immune cells are active and upregulated, and upregulation of the cell function is seen, such as phagocytosis, intercellular killing, and antigen presenting and cytokine release. In cytokine release, we have these pro-inflammatory mediators like TNF alpha, interleukin 1 beta, interleukin 8, and interleukin 6, which exaggerate pro and anti-inflammatory response, leading to the cytokine storm. So what are the conditions which cause uncontrolled cytokine storm? So it includes lung infections, acute pancreatitis, major surgeries, major trauma, and burns, which in turn leads to severe sepsis, ARDS, multi-organ dysfunction, and circulatory failure. Coming to the sequelae of immune dysfunction. So what happens here? The loss of immune regulation combines with shock, infection, inflammation, or any ischemia, which leads to development of systemic inflammatory response syndrome, most commonly known as SARS, which in turn leads to septic shock, disseminated intravascular coagulation, MODS, and other complications, leading to finally death. Sepsis. So as we all know, we have two types of immune systems, and how the immune dysfunctions with the sepsis. So in innate immunity, when it comes to sepsis, there is an increase in level of pro-inflammatory cytokines such as interleukin 6, TNF alpha, and interleukin 1, with increased levels of anti-inflammatory cytokines such as interleukin 10s and interleukin 1 receptors. The neutrophils, which enhance the spontaneous respiratory burst activity, are inhibited and cause inhibition of apoptosis also, and also impaired chemotaxis in response to chemotactic stimuli. So what happens in adaptive immune response in sepsis? There is a reduction in monocyte expression, reduction in the number of circulatory dendritic cells in spleen, increase in apoptosis of lymphocytes, reduction in global T cells responsibility, and also increased response to T cell independent antigens. Here is a wonderful picture which shows the pathophysiology of sepsis. Here we see the sepsis is only in between the interaction between the infection and the severe inflammatory and systemic inflammatory response syndrome. So here we see where there's an infection which leads to severe inflammatory response which further moves to infection with sepsis, leading to end organ damage, causing severe sepsis, and finally septic shock and death. ARDS. As we all know, the pathogenesis of ARDS is multifactorial, and it involves a diverse immune cells of both innate and adaptive immune system that mediates the propagation of lung injury triggered by an insult. The ARDS is mostly due to sepsis, which is a major component, followed by pneumonia, aspiration, trauma, and other minor includes transfusion, pancreas, and drug overdoses. So what is the pathogenesis of ARDS? Here we see when there is an inflammatory insult, which is caused by sepsis, trauma, transfusion, etc., there is an alveolar activation with activated macrophages via the signaling pathway of toll-like receptors 2, 3, and 4, and NLRP inflammasomes. So these activated alveolar macrophages release interleukin 1 beta, TNF, interleukin 6, and interleukin 8. We have two pathways where the neutrophils, where we see the degranulation necrosis causing epithelial damage, which causes reduction in surfactant layer, reduction in sodium potassium ATPase, reduction in ENaC, leading to reduction in alveolar fluid clearance. Whereas in macrophages, we see this endothelial damage, which increases the capillary permeability, finally leading to pulmonary edema and impaired gaseous exchange. Coming to the therapeutic approaches. So focus management and strategies in sepsis. So the mainstay, as we all know, the mainstay of a sepsis treatment would be early appropriate antibiotic therapy, followed by associated with aggressive fluid administration, use of vasopressins, and also prompt measure to supporting failing organs. And in ARDS, ARDS is recognized as a distant clinical entity less than 50 years ago. The development of rapid progressing respiratory failure, it is unusual. Within a couple of days, patient enter into an insult, and there is a very high mortality. It's up to 40%, which remains unacceptable. There is a lot of need to develop and the test therapies for this devastating clinical condition. So what are the immunomodulators therapies available in sepsis and ARDS? So what is the aim of immunomodulator strategies in sepsis and ARDS? Here, the immunomodulators in sepsis, it reinstates a balanced immune response to infection by decreasing the excessive inflammation, repairing immune reinfection. And also coming to ARDS, potential therapies, it is a potential therapy for both early and late phases. It potentially benefits by suppressing the pro-inflammatory cytokine response and also reducing the potential risk due to immune suppression. Here we have a beautiful picture where it shows that if there is a balanced immune response that leads to resolution of sepsis, elimination of pathogens, and tissue recovery. When there is unbalanced immune response, here we land up in systemic inflammatory response, which leads to excessive inflammation, causing acute organ dysfunction, leading to early mortality. And we have this compensatory counter anti-inflammatory response, which leads to immunoparalysis, causing secondary infection and late mortality. Corticosteroid therapy in sepsis. Well, this is a highly debatable topic, and it has a different school of thoughts and depends on individuals how they prefer. Like most of the studies, here we see in sepsis, corticosteroids are against in early sepsis. So there is no much of a role of steroids in early sepsis according to this article. But yeah, definitely according to the studies, we have a role of sepsis, a role of corticosteroid in severe sepsis and other situations where there is a history of adrenal insufficiency or use of corticosteroid usage, or there is non-responsive to fluid resuscitation and also moderate use of vasopressins. When coming to ARDS, here we have few studies where there is the use of different corticosteroids like methylprednisolone, hydrocortisone, and dexamethasone in different dosages and durations. But we see there is a very marginal difference between the mortality in control arm and in the treatment arm. Coming to HAT, this is also a very highly debatable thing, and it's individual's preferences where some studies show there is a good role and some studies does not. So hydrocortisone, ascorbic acid, and thiamine, the HAT therapy. HAT has recently emerged as a promising immunomodulator treatment where we use ascorbic acid at 6 grams per day, thiamine approximately 400 mg per day, and hydrocortisone of 200 mg per day. Some studies shows impressive reduction in organ injury and mortality in sepsis patients. Here in the graph, we see there is a reduction in persistent inflammation and progressive immunosuppression where the HAT therapy was initiated. Coming to ulanastatin, as we all know, serenase protease are involved in the systemic inflammation of cell apotheosis. Ulanastatin is a broad spectrum serine protease inhibitor found in human urine, blood, and other tissues, which acts as multiple levels. It has a potential antioxidant and anti-inflammatory effects, which has been approved by DCGI in September 2013 for sepsis. So what exactly it does? It inhibits serine protease like trypsin, thrombin, chymotrypsin, neutrophil elastase, and catapsin. And it also dysregulates inflammatory response. Like it reduces interleukin 6, interleukin 1, 8, and 4 TNF alpha C-reactive protein, and also it increases interleukin 10. Hematological stability. It normalizes coagulation disturbances, decreasing endothelial dysfunction, improves microcirculation, improves tissue perfusion, and promotes organ function and restoration. It inhibits apoptosis by increasing oxidation activity and reduction mitochondrial damage. So what is this role of ulanastatin in the progression in sepsis and ARDS. When coming to sepsis, we have different studies. We have 13 randomized controlled trials and 2 prospective studies, which shows approximately 1,400 patients with sepsis, severe sepsis, and shock have been treated with this, and which shows a good significant reduction in mortality, reduction in Apache score, reduction in MODS incidence, and also reduction in interleukin 6 and TNF alpha, and increasing interleukin 10 levels. There is no adverse effects, as there is no adverse effects noted. Coming to ARDS, the meta-analysis shows that around 33 randomized controlled trials involving 2,400 patients compared to the conventional therapy of ulnastatin has a significant benefits in reducing mortality, reducing ventilator-associated pneumonia, shortening duration of mechanical ventilation, and reducing the length of ICU stay. And in the phase 2 trials, it also shows improves in lung oxygenation and reducing hospital stay with low inflammatory cytokines and increased oxidative activity. Coming to another immunomodulator, which is thymosin alpha 1. It is an endogenous 28 amino acid peptide, mainly secreted by thymus. Acts as an immunomodulator, which is exerting a great biological influence in activating and regulating the functions of the immune system. So there are multiple studies which have been performed on this, and we have one study here which was conducted in 2008 to 2010 in patients admitted in ICU where there was severe sepsis. And coming to the conclusion, here we see the relative risk death in T alpha group when compared to the control group was a bit less, where the use of T alpha in a combination therapy with conventional medications may have improved the clinical outcome in targeted population with sepsis. What is a combination? Here we have few studies where they have used the combination therapy with thymosin alpha 1 and also ulnastatin. So the dosage of thymosin they have used in all the studies is around 1.6 milligrams, and the dosage of ulnastatin has changed between 2 lakhs and 3 lakh units, and the duration was also is different in different studies. But coming to the outcome results, which shows the decrease in mortality rate, that is the 28-day mortality rate and a 90-day mortality rate was good, decreased Apache score, and it also improves and it also shortens the mechanical ventilation time, reduces the vasopressin use, and reduces the ICU stay. What are the other therapies in sepsis? So we have intravenous immunoglobulins, we have non-pathogenic mycobacterium, we have GM-CSF, which is granulocytes, macrophages, colony-stimulating factors. We have interferon gamma, cytosorbs, therapeutic plasma exchange, TPE, and also multipotent mesenchymal stem cell. Coming to the conclusion, so currently evidence indicate target immunomodulation improves prognosis in severe sepsis and ARDS. So the choice of immunomodulators and the timing can be the deciding factor for the outcome of severe sepsis. Targeting immune response to prevent cytokine storm can benefit with early course of sepsis. It can be beneficial in early courses of sepsis. So we have a combination of steroid ulnastatin, which have shown a potential improvement in the mortality and outcome in ARDS patients. So these promising results with these agents suggest this potential. There is a potential to be integrated into the routine management of patients with ARDS and sepsis. As we see, the thymosin alpha 1 was approved in India for hepatitis B and C viral infection, and it has shown some beneficial effects in the management of sepsis. And ulnastatin was also approved by DCGI for the sepsis and acute pancreatitis in India in 2013. And that's all from my side, and I would like to thank the Urihk Pharma for giving me such a wonderful opportunity for presenting.
Thank you, Dr. Raghavendra.
Thank you so much.
Thank you very much. I mean, that was a very detailed elaboration of otherwise very complicated subject of pathogenesis and then leading to the treatment. I mean, it's like mathematics in my childhood. You remember only when you read it, like statistics.
Yes,
Later, you don't remember.
That happens to me also. Like, it's very complicated. I wanted to keep it as simple as possible.
But you made it very elucidated. Thank you for that. But the point is that once you know that these cytokines play pathogenesis and there's a therapeutic solution to that, utilization and using it to the advantage of the patient and extrapolating these results into other diseases, what I was calling repurposing, is something we need to go on. Because if you really stick to completely FDA or DCGI or other regulatory organizations approved drugs only, we could not have won the war or battled the war against COVID today or H1N1 10 years ago. we have been repurposing many times. So we want to learn from experience of very brave youngsters like you who are ready to experiment without taking risk, without taking undue risk. That is it. See, at the end of the day in medicine, in the risk benefit ratio, benefit should be more than risk. That's all it matters. And we can explain to the patient, I'm doing this and go ahead and do this. Now, I would like to, before we go to Dr. Ravi Kumar, I would like to ask you a couple of things. Basically, you were talking about steroids in ARDS and steroids in sepsis.
Yes.
Do you find as a pulmonologist, do you find any particular difference between different kinds of steroids? For example, between methylprednisolone and dexamethasone or betamethasone, because that was the debate that was ongoing when Act 2 trial came in COVID, about which we'll discuss later.
Yes.
That pulmonary penetration, anti-inflammatory activity, etc. Can you take a couple of minutes explaining your viewpoint on that
Yes. Yes. So initially,
from immunomodulation point of view as well?
yes. So like initially when we started using steroids, initially we didn't have a proper guidelines for that. So we started using a very low dose of steroids, and also like we were like very keen like how it's going to work, and we don't know what is the duration to give and which one to choose. So initially, first in my experience, we have started with methylprednisolone, and we have stepped up to 125 mg. So I have not seen any kind of any difference between methylprednisolone and dexamethasone when coming to the immunomodulatory effect or something, but both of the steroid had worked well for me. So the choice is completely depend on the availability, depends on the availability also. So sometimes like in a setup where we didn't have any much options, so we have gone for methylprednisolone. But after the FDA approved dexamethasone, there was a lot of buzz, because like whenever we started off with methylprednisolone, people wanted to shift over dexamethasone. So there was a lot of interaction. But for me, I've seen there's no much of a difference between both of the steroids.
Good. And then we will discuss about illustrating once Dr. Ravikumar takes you through the COVID as well. So I would like
Yes.
to take this opportunity to first thank you and then introduce Dr. Ravikumar, who
Thank
is
you.
an anesthesiologist with diploma in anesthesia and diploma in critical care from National Board, and a PG diploma in from NICU, then a PDCC. He is currently heading the ICU at the Sagar Group of Hospitals, Bangalore. We are happy to have him today evening at this symposium, this seminar. He's going to take us through something which is very, very topical. That is immune modulation and therapeutic approaches in COVID-19, which is the current pandemic trying to cause havoc across the world. And in some countries like India, we have the flexibility of using some repurposing drugs, and one of them have been immunomodulators. So just opening up the discussion, Dr. Raghavendra was talking about ARDS. All of us very well know there are two kinds of ARDS that was explained in COVID, and I'm sure Dr. Ravikumar will address that issue as well. So, will you be kind enough to take us in the next 20 minutes or so in about the immunoregulation and utilization of immunoregulation as a therapeutic approach in COVID-19 pneumonia? Dr. Ravikumar. Your mic, please, Dr. Ravikumar. You are mute.
Good evening, sir. Thank you very much for the
Yes, thank you.
introduction.
Thank you.
I think they have some technical issues. I'll just get back in 1 minute.
Sure. Trying to share your screen, is it?
Yeah, I'm not able to share my screen.
Bhavna or
So,
Abhishek?
finding any difficulty?
Yeah, I'm not able to share my screen. So just
So you can see share screen option on the down
The green one.
green one, sir. First, you please open your PPT and then click on that screen share option.
Can you see my screen now?
Not yet.
Good evening. Today I'll be discussing something regarding this modulation of the immune response in sepsis.
Sorry to interrupt, Dr. Ravi Kumar. No, sir, this is Dr. Vijay, sir.
Yeah, Vijay.
Sir, I think you have mistakenly opened the sepsis one, sir.
I think you should go for COVID-19.
1 minute. One.
sir. This is
Yeah,
the
yeah, got it.
presentation. Yeah. You can start, sir. I'll
Okay. Sorry for the delay because of some technical issue. I could not get the slides. Okay. Thank you very much for the introduction, sir. So when we're talking about this COVID-19, the most important aspect of this COVID-19 is always this cytokine storm. Because when you know this COVID-19, because of this virus, whenever you get into this sort of scenario, it is not only the virus which that causes the entire scenario. It is because of the release of the cytokines. It is because of the release of the macrophages and the T lymphocytes, and because of this, you have something called as a cytokine storm. So what happens when actually there's a cytokine storm? When there's a cytokine storm, there's a tissue damage usually which happens, and because of the interleukin 6, the interleukin 1 beta, and the tumor necrosis factor, because all these things are released into the circulation, there is something called as a leak which happens in circulation, which happens in the various organs. This leads to an endothelial damage, the capillary leak syndrome, and what we happens to the lungs, what we see is the acute respiratory distress syndrome. So these cytokines have action over your total counts. It has an action over the reactants. It has an action over your respiratory epithelium. It has an action over the dendritic cells everywhere. So you have an end organ damage because of the most important cytokine storm if it is not controlled at an initial phase. So what is the use of treating the cytokine storm? Because should we deal with the cytokine storm or should we deal with something else? Because what happens is that whenever there is a cytokine storm, you see that if this cytokine storm is not stopped at an initial stage, what happens is an anti-inflammatory response is not started. Then if it's only a pro-inflammatory markers which are going on increasing, then you see what happens is, if there is no modulator therapy or any therapy which was going to change this inflammatory response into anti-inflammatory response, this might lead into a cytokine storm which continues into a permanent septic shock and a death of the patient also. So some medium is required or some sort of therapy is required at this point of time, wherein it comes in between the treatment of the conventional treatment, and it helps for most of this early recovery of the patient, wherein there is an immunosuppression, and it brings about a hemostatic balance. It brings about a recovery in the tissue, the homeostasis. It brings about a recovery in the organ functions, and that's what is the main action of immunomodulator therapy, which is of usefulness in this scenario. So again, immunomodulators are again non-specific immunomodulators and specific immunomodulators. If we talk about the non-specific immunomodulators, something like steroids, dexamethasone and methylprednisolone, which are extensively used during this COVID-19 scenario. And next comes the thymosin alpha, which is actually used for hepatitis, and it was used as an immunomodulator in the patients with HIV also. And it was seen that this also had some action by acting against the T helper cells, and it had a role in the COVID-19. Coming to the next is antibiotics such as azithromycin, clarithromycin. Next is hydroxychloroquine, which became suddenly a very famous pill in the early 2020s. But again, its efficacy is again a question mark. Then heparin, yes, heparin is widely used, and vitamin C, yes, this vitamin C is it was used in sepsis also, along with thiamine and corticosteroids. So vitamin C also is comes under the non-specific immunomodulators. And talking about human immunoglobulins, this is of slight importance, interesting importance for me, because in this scenario, we had some patients wherein all the conventional therapy was not at all working. Then we had to start using, we used the steroids, we used the thymosin alpha, we used everything, conventional therapy, whatever used for other patients, but we were stuck. So we thought that let's use immunoglobulin, because we were in a situation where if we were able to lose the patients. And this has, interestingly, we are collecting the data also, and we are going to present a paper on this. And we saw that immunoglobulins also had a role. I don't know how was the role helpful for in controlling the COVID, but we had some very good results because of immunoglobulin. Coming to specific immunomodulators, we'll be having the ulastatin. And with my experience in specific immunomodulators was with ulastatin itself, and next was tocilizumab, itolizumab, and when nothing was available, we started using even the bevacizumab also. And now recently we have started using baricitinib. Convalescent plasma was not very helpful. Yes, it was helpful during last year initial days when we thought that is going to be useful, but they say that only the high titer antibodies only is going to be useful for the patients. But I don't know, because convalescent plasma was always a question mark in my mind whether to use for the patient or not. So again, it is not. It becomes nowadays. I think it is also. It has been said that it's an off-label medication. So that goes. Okay. So what happens when the immunomodulators are used in the COVID-19? So what happens is there is always there's an induction of all the cytokines such as interleukin-6, the tumor necrosis factor, and all. So because of this, there is again what happens. It brings, whenever you use all this immunomodulator, whether this is specific immunomodulators or non-specific immunomodulator, they have a particular role to play. Like if you use a tocilizumab, it brings down the IL-6 levels. The same with the itolizumab. And when you start using the ulastatin, it has actions of against the interleukin-10, interleukin-6, and the tumor necrosis factor. Then talking about this absorption therapy, such as cytokine absorption therapy, it is directly related to the cytokine filtration, but it is not related to the endotoxins at all. Okay, talking about the corticosteroids, they have very severe COVID-19 inflammatory response, very helpful in lung injury and the multi-system organ recovery. The recovery trial already showed that the mortality from COVID-19 was lower among the patients who were randomized to receive the dexamethasone than among those who received the standard of care. See, there was always this controversy between the corticosteroids, whether to use dexamethasone or hydrocortisone or any other corticosteroids. But I feel that whatever the steroids, whether the methylprednisolone or whether it is dexamethasone, so whatever was we used, I don't think one had advantage over the other. It was just the steroids which were acting, and I think everyone will agree with me in this point. Monoclonal antibodies, tocilizumab. So, tocilizumab, last year when we were using for the COVID-19, it was available, but this year it was a big shortage all over the India about for the tocilizumab. I don't think that we could use because tocilizumab as many numbers as we used in the last 2020. So tocilizumab, it usually targets the interleukin-6 receptors and it blocks their action. It was actually used for the treatment of rheumatoid arthritis. In the recovery trial, around 4,116 hospitalized patients with COVID-19 were received either tocilizumab compared with the standard of care in UK. And this was done a study from April 23, 2020 to January 24, 2021. Among those not receiving invasive ventilation, the patients in the tocilizumab group were more likely to be discharged from the hospital within 28 days. Among those not receiving invasive ventilation at baseline, patients who received tocilizumab were less likely to reach the composite endpoint of invasive mechanical ventilation or death. There was another study called as Covactor randomized study, wherein the trial did not meet its primary endpoint of improved clinical status in the patients with COVID-19 associated pneumonia, or secondary endpoint of reduced patient mortality. This trial, however, did show a positive trend in time to hospital discharge among patients who received tocilizumab. Coming to the itolizumab, this was a drug which recently got an approval by the DGCA for the use in the moderate to severe COVID-19 infection. It is an anti-CD6 monoclonal antibody. It is used for various cancers earlier, and this drug is now, it has been repurposed for use in COVID-19. A phase 2 multicentric study was done using 30 patients in India, wherein the 20 patients were randomized to receive itolizumab plus supportive care. While 10 patients received supportive care alone, the other patients received itolizumab. They recovered fully and were discharged from the hospital whereas the 3 out of the 10 patients in the control arm died. There was also significant improvement in the key parameters of lung function such as PaO2 and SpO2. And in my personal experience, because we have used a lot of itolizumab in our ICU setup, because when, as I told you, the tocilizumab was not available, so next better choice what we had was an itolizumab. So one thing what I noticed after using itolizumab was after using the itolizumab for 8 hours or the 9-hour infusion, the next day morning when we used to check for this IL-6 level, there was a significant decrease in the IL-6. So a very important drug in COVID-19. Bevacizumab, this was a drug when we were started using it, not because we wanted to use it, because we wanted to use it because there was nothing else was available during this year crisis. So this usually blocks VEGF and VEGF receptor mediated signaling receptors. It improves oxygenation perfusion and anti-inflammatory response. The optimal dosage for COVID-19 was unknown, but we started using 7.5 mg per kg IV. Trials were done in China and Italy regarding this bevacizumab, but personally, I'm not very convinced about this use. Okay, this is a new cocktail. This is casirivimab and imdivimab antibody cocktail. Personally, I have no experience regarding this, but there have been trials regarding this because it's made from a combination of 2 monoclonal antibodies, and there was a study wherein the 275 patients either got 2.4 grams of Origin or 8 grams of Origin CO2. Symptoms cleared after 6 days, 8 days, and 30 days respectively. Regeneron reported that this particular combination reduced viral load and relieved symptoms in patients with COVID-19 who are not hospitalized. There have been some conditions wherein they have started using this, and it looks that in the mild to moderate cases, this is a very promising cocktail. This is another immunosuppressant called as a baricitinib. It's a JAK inhibitor. It also has an AAK1 inhibitor also because it interrupts the passage of the virus into the cells and can help prevent virus infections. It is used in combination with remdesivir for the patients who are hospitalized with COVID-19, and they say that after starting using that, the oxygen requirement of the patient or the invasive ventilation, whatever the patient is going to have a worsening of the respiratory failure, they are going to be improving. But it's still we are still using it, but we have not arrived at any consensus regarding baricitinib. So till now, we have seen that the therapeutic options such as the steroids or the monoclonal antibodies to modulate immune response in critically ill patients is as a respiratory therapy, and the MABs are in a very short supply. These molecules also have a number of limitations wherein they have some immunosuppression, bacterial and invasive fungal infections, avascular necrosis, anaphylactic reactions, and they're also contraindicated for patients with certain organ failures. As a clinician, based upon our past experience, we are using other repurposed immunomodulators like ulnastatin and thymosin alpha. These products have shown a benefit in controlling cytokine storm when used at the right time, at a right dose in patients with sepsis, ARDS, and pancreatitis. So coming to the other immunomodulators, the most used one is an ulnastatin. It's a broad spectrum serum protease inhibitor. It's currently available for the treatment of severe sepsis, ARDS, and mild to severe acute pancreatitis, as approved by the DCCI. It's used for the prevention and treatment of cytokine storm in COVID-19. It brings about a reduction in tumor necrosis alpha, interleukin 1 beta, interleukin 6, interleukin 8, and it has a confirmed significant efficacy in removing the oxygen-free radicals, improving the microcirculation, tissue perfusion, and elevating the endothelial injuries. So there has been a lot of debate regarding the dosages of the ulnastatin, like when it has to be started and what is the ideal time to start. And I think every institution have their own protocols for starting the ulnastatin, and they have their own protocols for the dosages also. This was an article which was seen in the Journal of Infection in 2020. So it claims that Low doses of corticosteroids might be considered for the patients with septic shock, but ilnostatin is a broad spectrum enzyme inhibitor, and it could protect the pulmonary functions from being harmed by a variety of factors from extracorporeal circulation. In addition, the morbidities of the stress ulcer, hyperglycemia, and fungal infection could be further low after the use of ilnostatin. Furthermore, the ilnostatin has also shown a promise in replacing glucocorticoids for the clinical management of ARDS. Therefore, ilnostatin might be considered as an alternative therapy of glucocorticoid for patients with severe or critical H1N1 infection. So nowadays, thymosin alpha 1, even last year, we also started using thymosin alpha, and we also had a lot of press releases regarding its efficacy. So it could prevent a pro-inflammatory cytokine storm by itself increasing the helper T cells or the regulatory T cells. It's used in the treatment of hepatitis B. It was actually used for the treatment for hepatitis B and C, and it is under clinical trials in USA for COVID-19 now. In 8 government-designated treatment centers for COVID-19, wherein it included 4 intensive care units and 4 general wards in 3 cities of China, that is Guangzhou, Shenzhen, and Wuhan. And after using this, they revealed that thymosin alpha 1 administration could significantly decrease 28-day mortality among the critical type COVID-19s. Moreover, thymosin alpha is obviously attenuated acute lung injury, as evidenced by the improvement in a PaO2 by FaO2 in the thymosin alpha 1 treatment group. So, cytokine storm is inevitable in a critically ill patient, and immunomodulator therapy is the cornerstone along with the antiviral and supportive care. Steroids are not alone enough in certain patients. Even monoclonal antibodies have a role to play when used judiciously and considering their safety issues. Moreover, they are in short supply. Based on the past clinical experience of managing similar critically ill patients, we are using already available certain drugs normally used in sepsis to prevent the cytokine storms like ilnostatin and thymosin alpha. These drugs should be added in moderate illness of patients of COVID-19 having to prevent the possible cytokine storm. The most important thing is the dosing and the timing of using them are very important. Thank you very much.
Thank you, Dr. Ravikumar. I mean, that's a step forward in the managing of dysregulation of cytokines, including cytokine storm. And your experience is also interesting. Before we take it to the panel, I would like you to elaborate a bit more on your experience with itolizumab. It's very interesting what you said, that I did not use itolizumab. I myself have no experience, and you seem to be having good experience of using itolizumab in your patients. Probably, yes. Could you elaborate a bit more, the numbers, I mean, survivals, etc.?
Okay. I don't have the exact data as of now, but I can just give an approximately a vague picture. Well, we never used itolizumab in the last year. We started using itolizumab only during this scenario in the last 3 months. Last year, we had used in some patients, in around 8 to 10 patients. This might be in the month of October or November last year, when we started first looking at the efficacy of this drug. And initially, we had a lot of issues with this drug because we had a lot of allergic issues and anaphylactic reactions when we started using this. Then we formulated a way of giving this and a way of infusion for a long period of time. So that's how we started elevating from the anaphylactic part of the thing. So this year, if I'm not wrong, we had used in more than 60 to 80 patients itolizumab. And whenever we have used, when we was witnessing that the IL-6 levels were going high, the patient was in a phase when we are starting from NRBM, he's going into the NIV. So that was a time when we used to usually start using itolizumab. And the patients who you came early to the hospital and in whom we used this, we were able to manage them with the NRBMs only and after using after 24 hours, we used to see that the IL-6 levels had dropped drastically. If I say the IL-6 levels were 200 or 250 or something, the next day morning we used to see something like 35, 41 or 50. So this was something which was a very good thing for us, because we used to see, because we also used to see that IL-6 levels every day going up in the patients. And after giving itolizumab, we saw that IL-6 levels are coming down. The requirement oxygen is to come down in the next 48 hours. And the patients whom we thought that they will end up in a HFMC, they'll end up in a intubation, we saw that they didn't need anything like that. But the major catch in itolizumab was, what we found was, the way of administration is very important. If you start using like tocilizumab or bevacizumab, then you'll have a major anaphylactic reactions. And it was a case that last year we even lost a patient because of the same issue, that we had given it for 4 to 5 hours, and the patient had anaphylactic reactions, and we couldn't, the registrar in the night couldn't even recognize that what was happening to the patient. So that's a major thing with the itolizumab.
Right. As everybody in this learned panel would agree, one of the serious problems we faced over the management of COVID, and even in the days when we used to use steroids for sepsis and steroids for ARDS, let us say going back by 5 to 10 years, is sepsis, in secondary infections. I think the wonderful thing that came up through these immunomodulators, especially when you talk about ulinastatin in the current setup, or you talk about baricitinib in the trial that was released about 3 months ago, there is a steroid sparing effect. If you use these drugs in the appropriate time, I think the steroid duration or utilization of steroids can come down. And of course, there's a subset of patients in which you cannot use steroids. Uncontrolled diabetics, for example, we cannot use steroids because we face other problems there. So those things we will discuss during the panel discussion. Thank you very much for the enlightening talk that you have given, and Dr. Raghavendra and you worked in tandem, one after another, to give the total picture of immune dysregulation in sepsis and COVID-19, and how the immune regulators can be used beneficially. Now, may I have the pleasure of inviting our panelists? I request all of them to switch on their videos. Dr. Jyoti Hatiholi is a pulmonologist, MD Respiratory Medicine. She is an associate professor in Jain Medical College. Second panelist is Dr. Hufeja Suratwala Ismail. He is a DTCD, pulmonologist as well, and DNB. DNB in general medicine, so it's both a physician and a pulmonologist. That's a great combination to have. And the third panelist we have is Dr. Debshis Barik. He is a general physician, MD general medicine, and is consultant in Best ECT Hospital, Bangalore. And I request Dr. Ravikumar and Dr. Raghavendra also to join the panel, and we'll get the ball rolling. I would request the new entrants, Dr. Jyoti, Dr. Debshis, and Dr. Suratwala, to put in some opening remarks. Dr. Jyoti, your opinion and input about the broad topic of immunoregulators and your experience.
Yes, sir. Coming to the current scenario we are in, when it comes to sepsis or ARDS in non-COVID patients, the only thing which we have used before was steroids and steroids only, may it be a low-dose steroids, which we are familiar with. And during the COVID era, we have, if we go as per the guidelines, then it is only the steroids which are recommended by the guidelines. But we are not able to just wait for the guidelines, the more these things to inputs to come in from the guidelines. So we have to go a step forward, and we have started repurposing, as you told, many of the drugs, like both specific and non-specific immunomodulators. And my experience towards immunomodulators is basically steroids, which we have regularly being used. And also some of the other drugs which we are regularly being used are like anti-interleukin 6, which we are using regularly. And as Dr. Ravi Kumar told, we have been using itolizumab regularly, sir, and
Right.
also the JAK-STAT inhibitors.
Looks like Karnataka is using itolizumab more. I mean, like, because sitting in Hyderabad, I did not hear so
More
much
of
about
availability
itolizumab.
issues, sir. That is what
Probably.
that's what is available for us, probably.
Excellent. And Dr. Debshis, what is your broad experience and the major difference between the pre-COVID time and the intra-COVID time? We're still in COVID time. Intra-COVID time about using immune modulators and immune dysregulation.
First of all, thank you. Thank you, sir. Thank you for the invitation, and thank you for a brilliant session that Dr. Ravi Kumar and Dr. Raghavendra has presented. It is an immense pleasure actually to be in. Sir asked a very broad question to me, that what is the difference in pre-COVID and the intra-COVID. The major thing that what I can tell is not about the treatment, but managing the crisis. We had never in our lifetime had been in such issue where we have to literally triage the patient, like who we should take in the hospital, who we can treat in the OPD basis. And that is a major thing that we had to do in this pandemic time, and which was, of course, the toughest job what I could do in my whole career. And coming to the treatment per se, of course, it's a big challenge for treatment, because this is a new disease. We are still learning a lot of things about the disease. We are still, I think almost all the panel will agree that we still don't know how COVID will behave in which person. That is the one line what we can tell, that we still don't know. Even after managing so many patients, even after managing more than 1,000 cases in the last 2 months, I still don't know how COVID will behave how in one individual. That is the biggest challenge that we are having. And another most important thing is the availability of the drug, which Dr. Raghavendra told. Like there are trials which are telling whether dexamethasone or methylprednisolone is superior, but we have to manage according to the availability of the drugs. Sometimes we will be run out of dexamethasone, sometimes we will run out of methylprednisolone. But having said that, the pre-COVID times, as Madam Dr. Jyoti told, we were using low dose steroids, of course, in ARDS patients. But during COVID times, of course, with a lot of trials ongoing and with a lot of new drugs coming to the market, and when it is a challenge that how the drug will behave in certain individual, we have the liberty to use some of the immunomodulators, of course, with the having taken taking a very minimal amount of risk. So in that, my personal use, I have used, of course, steroids we have used. I have used more of methylprednisolone than dexamethasone. And coming to the immunomodulators, I have extensively used ulinastatin because of its availability, at least in Bangalore. And coming to itolizumab, I have used a few patients with itolizumab, and tocilizumab, of course, with few patients with tocilizumab. But of course, there is an extensive use of ulinastatin, which has given good results after about
Yes,
7
sir.
to 9 days.
Yeah, we will talk about ulnastatin in a bit more detail in a moment.
Yeah.
But I would at this point, thank you very much, Dr. Vishesh. At this point, I would like to go to Dr. Suratwala, asking his experience, especially in the pre-COVID era regarding steroids and ulnastatin. We'll come to ulnastatin in COVID era a bit later. Have you used yourself ulnastatin with or without steroids in the sepsis ARDS phenotype? Dr. Suratwala, your mic is mute. It is muted.
Good evening, everyone. Thanks for inviting me. Sir, I had used ulinastatin in pre-COVID era in cases of pancreatitis. Acute pancreatitis, I used to see some patients where ulinastatin is indicated, and studies have also shown that it has a good effect in pancreatitis. It reduces the inflammation. So I had found it useful in those cases. And steroids, as usual, we had used in sepsis, low dose steroids, and that actually helped the patients. It reduces the mortality in cases of sepsis, septic shock. And coming to the COVID era, as all the panelists have told, steroid is the initial choice of drug to reduce the inflammation. But if you want better effects and the patients are not responding that much, I started using ulinastatin. Since I had that memory of using in pancreatitis, I thought of using it in COVID also, and I found it useful. Like saturation started improving. In the next few days, 2-3 days, it started improving, and the inflammatory markers also started reducing. So my choice was like initially in COVID, I used to use steroids. Then once the patients are not improving, I switched on to ulinastatin. And then depending on the availability, I used bevacizumab. There was no availability of itolizumab and tocilizumab. But cases of bevacizumab, I found some patients are responding very well, but some patients there was not much response. So it was like not a throughout a good response with bevacizumab.
Right, sir. I mean, I do agree with you. I did use ulnastatin in our team in several cases of COVID. Before that, just like Dr. Suratwala, we have used it in pancreatitis. We had good results when used early. That brings us to the question of timing. See, the in the search for the holy grail for sepsis management. I think it has been about 50 to 60 years that we are struggling to find a single agent or a combination of minimal agents which clearly give us a result. We came very close when drocatrogen alpha activated protein C was marketed between 2001 and 2009, and some of us we were in the practice at that time did use it with certain amount of results. That is a single targeted molecule, but for obvious reasons and failure of establishment in the later clinical trials, that drug was taken away from the market. So from 2009, 2010 to today, we don't have a single agent. And then came COVID. In that scenario, where we are still struggling with sepsis, you all might have studied and known the Corticus trial, which did not prove the ultimate use of steroids in sepsis. It could not prove this use. So we were actually at loss of a single effective agent for immunomodulation in sepsis before COVID. To compound our problems, COVID came and hit us with such a force that the immune challenge on the system itself started killing our patients. So we had to dig out all our armamentoria, including drugs like vilnastatin, and repurpose them to C. Now, if you take any sample patient from your ICU or ward, he is not on a single drug. He is on more than one or two drugs which can play with the immunity. So it's very difficult to say which one of these drugs have acted either positively or negatively. But yes, broadly, if you say, for example, I compare between my practice and Dr. Surattala's practice, who used more vilnastatin and I used less vilnastatin, probably you can see the difference in outcome. So this all comes down to one simple question. The question is, if you have an immune modulator, for example, vilnastatin, when to use it? Because in our country the referral system is not very straightforward. Nobody knows when the patient will come to you. Patient may come to you on the first day of his illness or 10th day of illness after another hospital or another group of doctors have treated him. So I would like to elicit your opinion, starting from Dr. Ravi Kumar. When, at what stage of disease you would use a immunomodulator? Whichever immunomodulator you use, your choice. We all know patient is under immune modulation. There is a pre-cytokine storm stage and a cytokine storm stage. Then sepsis comes in the third stage. Sepsis comes in. Patient may present to you at any point of time. So in your cohort of patient, Dr. Ravi Kumar, what is the best time to use immunomodulators?
Before talking about the COVID, let me talk about the sepsis, because my first interaction to vilnastatin was in 2016. I started using for the patients for sepsis. So whenever the patient used to come to the hospital, as you told me, because of this referring scenario which is there in India, if a patient is already treated in some other hospital, he already is in shock, he already has one or the other organ is already involved, and now he comes to my hospital, I don't think that vilnastatin will work at that part of the time when he has already lost the first 5 to 7 days in other hospitals. At the same scenario, the patient comes to me on the day 1 or the day 2, and I admit the patient and I start working out what's happened to the patient. I said, wait for the lab investigation for the next 6 hours. Once the lab investigation comes and I see my procalcitonin levels very high and the patient is already on a single vasopressor, I think that is a time, that's the initial time, is the best time to start using vilnastatin. And I think if you start using the vilnastatin at the day 1 or after the second day of the admission, of the onset of the symptoms, I think that's the best part. And I think we can do a lot of justice to the patient also by using this immunomodulator.
Thank you. And Dr. Raghavendra, I mean, do you generally agree with the timing that Dr. Ravi Kumar is saying? And if at all you agree, what is the dose in which you use?
So thank you very much. I agree with Dr. Ravi Kumar sir, because in India we have a situation where patient goes hospital shopping most of the times, and by the time he lands to us, we have lost the golden hours. So, but I would definitely try to use the vilnastatin as late as 5th or let's say 5 to 7 days also, because it might help us in some point of time. But knowing that it won't give us much beneficial effects. So, if the patient present to me at very early stages, I think that would be very beneficial in sepsis and ARDS patients. And coming to COVID patients, so according to my experience, I have used it in patients who are presented to me at 10th day of infection also, but it somehow helped me preventing them from going, preventing them from increasing in the oxygen requirement, and also other severe secondary infections also. So,
Good. I understand that. So you don't mind using it a bit late also.
Yes,
Not
I
only
have
on
used
day
it
one, day two, you don't mind using it a bit late also.
a bit later.
But Dr. Jyoti, do you think that is safe? Like we have a lot of controversy about the safety of immunomodulators because as we began this discussion in the risk-benefit ratio, safety plays an important role. We should not be risking. For example, if you compare your MABs to your steroids to agents like unistatin or even thymosin alpha, what do you think about the safety profile of these immunomodulators?
Sir, thank you, sir. So, whenever a patient approaches me, we usually try to classify these patients into three groups. Like either they are in the viral phase of the illness, or they are in the pulmonary phase, that is a pro-inflammatory phase, or a later inflammatory phase, or a dysregulated immune phase. Like they are in the cytokine storm already. So, that becomes very important for us. So somewhere between fifth to until 10th day of illness, we can take it as a viral phase. Like obviously there will be a overlap between all the phases. Then somewhere between 7th to 14th day will be the pro-inflammatory to inflammatory and then the cytokine storm. So if the patient turns up to me somewhere between 7 to 14 days, then right from corticosteroids till the Jackstats to ulirastatin, this is the right time to hit the patient. Anything earlier than this, I will be causing more harm to the patient than benefit because I will be increasing the viral shedding in the patient. And if we suppose the patient lands to me somewhere after 14 days, when already the mods has set in, probably the immunomodulators may not be as beneficial if I miss this golden period. That's what is my take on this.
Yeah, I got it. But speaking from our pre-COVID experience, Dr. Jyoti and I will go to Dr. Debashis now. I mean, from our pre-COVID experience, we have seen some beneficial results from immunomodulators even in H1N1 period or even sepsis, for example, ARDS or pancreatitis, which is also pro-inflammatory state. What do you think, Dr. Debashis? Do you think we can still take the risk of actually using immunomodulator slightly delayed phase? Of course, early phase steroids, Dr. Jyoti put a very valid point about viral shedding and more harm to the patient. So in that stage, you are not going to use steroids. But Dr. Ravikumar said, and then Dr. Raghavendra said that even from the early to intermediate phase, they are okay to use illustratin. Now you come into a slightly delayed phase. Let us say second week, 10th day, around that period, are you comfortable using and how do you compare? Because by that time, according to Dr. Jyoti's argument, it is safe to use steroids. Viral shedding is over, viral phase is over. So it's safe to use steroids. Patient is probably hypoxic at that stage. In that phase, do you think it is still safe to use steroids plus ulnastatin?
Sir, actually, I would take a call if the patient has presented, of course, to me in the early part of the disease. Then, of course, as Dr. Jyoti told, I will take that timeline. But if the patient is presenting late, suppose the patient has already been treated somewhere or patient has got home isolation, and as you know, a lot of patients, they take the risk of not coming to the hospital till their saturation is 88 to 90 at home. Maybe by then the patient are already incurred the disease from last 12 to 14 days in the second week or third week the patient is present into the hospital. Then of course I will take the risk of starting ulinastatin, of course, or any other immunomodulator which is available to me along with corticosteroids. But if the patient is already there under me in the hospital, especially in the COVID time, I won't take the risk of starting the ulinastatin or any other immunomodulator late second stage or third week, late second week or third week. I would definitely start by 10th day if the patient's oxygen requirement is going up or if the patient's CRP value is very high and it's not coming down only with steroids, then I would definitely not delay the treatment of immunomodulators.
Uh, Slightly stepping back to what Dr. Ravikumar was presenting regarding casirivimab and imidivimab, the cocktail that has entered the market region on, it is that exact stage that you are talking about, Dr. Debashis, that before patient comes to hospital, if he is getting sicker and mildly hypoxic, that this cocktail is supposed to be helpful. Of course, hospitalization is a very relative term. When they did trials both in Europe and US, they were very strict about hospitalization. But in India, hospitalization is a vague meaning. I mean, if someone known to me, I'll hospitalize him even in early stage, or he doesn't have money, he doesn't get hospitalized until very late stage. So I think that class should be kept aside. And another good, interesting thing about this cocktail, it can be used in pediatrics also. Why I'm saying this is, we are slightly apprehensive about the third wave, which may affect the pediatric age group more. This cocktail is repurposed for pediatric age group as well, with change in mild doses. Of course, none of us are pediatricians, but that's an interesting point. And it's pretty safe. There are no side effects. So we should keep it on the top of our mind as an immunomodulator, which can be used. Of course, if the patient enters hospital and if you have to fit into the recovery trial criteria, you can use steroids. But now taking it forward, I mean, if you see, how much is the dosage and duration, Dr. Suratwala, that any immunomodulator, like for example, Statin again or thymosin alpha, how long would you use? Nowadays, before I let you elaborate, please share your experience also. In second wave, patients are having longer length of stay in the hospital and in ICU. Do you all share the same experience than first wave? My patients are there are patients who are there in ICU for more than 40 days, 45 days now. I mean, maybe they're younger and fighting better, but at the cost of hanging on for a longer time. So, in this scenario, Dr. Suratwala, how long would you use one of these immunomodulators? Duration of treatment.
Sir, regarding ulinastatin, actually, once the saturation starts dropping, inflammatory markers start increasing. So that is the time I started using the ulinastatin, and the dose I used was 2 lakh units twice daily, and I have given it for around 5 days to 7 days, depending on the response. If I'm getting good response, I used to use it for 4 to 5 days, and if it is a slow response, I used to just prolong it, just for the benefit of the patient. I just used to see whether it's having any benefit or not.
I mean, what is the longest duration you have used, Dr. Suratwala?
I've used for 1 week.
Anyone else has used it longer for benefit of the patient?
Sorry?
Did any other colleagues of ours use it for a longer period?
I have used actually 2 lakh units thrice daily. I have used for about 9 to 10 days.
Right.
For some patients, I have used.
I've also used it for around. Sorry, I have also used it for around 10 to 14 days, sir. It was a younger patient, so he was only 33 years, and we wanted to hit him hard. So I've used it for 14 days actually, and it was a very good recovery because his CT severity was 25 out of 25 when he presented to us.
And in your case, Dr. Barik, did it result in a positive outcome?
Yes. The patient did recover. And actually, initially, the patient's CT severity score was 12 by 25. After giving ulinastatin, the patient recovered. But when we did the repeat CT, the CT was actually 22 by 25. But there was a clinical recovery of the patient. Right. So in that case, the patient had received ulinastatin for about 12 days total. And after that, the oxygen requirement also had come down. And we initially thought of starting tocilizumab for that patient, but we didn't find tocilizumab. So we went ahead with ulinastatin. And of course, the patient recovered. Patient was 35-year-old.
There is a study that Dr. Ravi Kumar was showing. Yes, sir, I was coming to you only. There's a study which you have shown where thymosin alpha and ulinastatin were used together. Do you have a personal experience of using them together?
No, sir. I was a big fan of thymosin alpha in the first wave, and during second wave also started using. As we were talking about this shortage of drugs, so the same I even faced in Bangalore for thymosin alpha, and I had a patient in whom I couldn't use a larger amount of steroids because she was diabetic, her sugar levels were very bad. So the only thing which I had was thymosin. I used thymosin almost for TID, 2 lakh units TID for 14 days I used. And this patient went on the ventilator. She had a tracheostomy done, and she came out of the ventilator also. So with ulinastatin, I never had any experience in COVID, but this second wave, I used many patients used this ulinastatin, and I'm very happy that the patients have come down. See, there was a cocktail what we used for the patients in this year of the COVID. What may help the patient. But definitely ulinastatin was not there during this cocktail last year. I was using a lot of thymosin alpha, but this year we just changed to the ulinastatin, and we used it for as Dr. Raghavendra also told. I had used this for 14 days, and right. I think and I had a very good result with that.
That's very good. In sitting in a country like India, I mean, it will be injustice not to look at the cost-effective ratio of any agent that we use in any patient, not only COVID, for any patient. So now that several immunomodulators are there, some of them are very expensive, and when we talk about expensive, we have to include the expense of the complication also. For example, if you use something like tocilizumab, my unit was very, very unhappy with tocilizumab. We used tocilizumab extensively in the first wave, both our pulmonologist and our intensive care colleagues. And we had a slew almost, I think we treated about 2,000 patients in the first wave in our ICUs. And our secondary infection rate shot up. So when you use an agent, an immunomodulator, which has a lower profile of complication, obviously the cost comes down. And of course, the mortality also comes down. Now, in the second wave, because of other factors, we're still suffering from some amount of secondary infections. So, I want to take a last round of opinion from everyone how we can utilize these immunomodulators while improving survival and reducing risk factors, and also to the cost sparing benefit. Now we are talking about steroid sparing benefit, but we have to talk about cost sparing benefit also. We'll start with our lady colleague, Dr. Jyoti.
Sir, I would like to make a statement that if I don't do any benefit to the patient, it's fine, but let me not do any harm to the patient. That should be the basic dictum. So if we go with that dictum in mind, then definitely ulinastatin and capuchin alpha stand first because they are very safe. They don't have any adverse effect profile compared to other drugs. But at the same time, since there is no strong evidence on these two drugs, we also have to somewhere start or somewhere even try other modulators also. So yes, sir. Uh, Depending on the condition of the patient,
Yeah.
to take the decision at the right time.
Yeah, but asking for strong evidence in COVID time is a very big demand. You know, I don't think we are ready to afford it even at an international level. So taking your cue from that, Dr. Suratwala, how do you manage? All of us are managing patients of various categories. Poor, middle class, rich, everyone. How do you manage to cut costs, especially regarding managing things like cytokine storm in your practice?
Sir, the best agent was steroids. So most of the patients, they respond to steroids. But once the storm increases, the inflammatory markers, they start increasing. So we will think of other drugs, how we can benefit the patient. So in that view, the ulinastatin used to come next because of the cost benefit analysis. The cost of ulinastatin is very much less compared to the tocilizumab. But over a period, if you give for a longer period, the cost, it becomes same. Ulinastatin also, if you give twice daily for 1 week, 10 days, the cost again it becomes the same. So you have to decide. You have to take a call depending on how's the patient condition, how's the patient background. So if you are giving ulinastatin for few days, 3 days, 5 days, or 1 week, that is okay. Cost wise, it is okay. But still, if they don't respond, and then it's a very tough decision. You have to see the background of the patient, and then seeing the age of the patient also. If it is a young patient, you try to save the patient. You do everything what is possible. Wherever there is little evidence, you give that. So next, we can think of using the tocilizumab and other drugs.
Yeah, what
Just
you're
because
actually saying is what one of our colleagues mentioned, a very important word called triage. In the times of crisis, in the times of resource limitation, triage becomes very important. You know, of course, that's a political decision as well. It's not a pure medical decision whom to give what and whom to let live and whom to let die. That's beyond medical profession. So triage is an ethical issue. I understand what you're saying, but I will ask the same question to Dr. Devashis in a different manner. For example, you have started some immunomodulator of your choice, maybe ilnastatin, and you feel at some point that it's not working. What are the indicators that you think they're not working, and would you discontinue it?
Yes, sir. Actually, yeah, once I start illuminastatin, for example, any immunomodulator, let's say it is illuminastatin, I would observe the patient for about 48 to 72 hours. I won't take a decision after next day, but at least 48 to 72 hours, I'll observe the patient, whether the patient's inflammatory markers are coming down, whether the patient's oxygen requirement is going up, whether the patient is clinically deteriorating. So taking everything into consideration, then of course the cost issue also will come into picture, and the availability of the other immunomodulators like tocilizumab or itolizumab. Suppose there is an availability of tocilizumab. If the patient, like as most of us know, that it is a drug that has to be procured, and of course patients To get the drug, it takes 24 to 48 hours to get the drugs after procuring the drug. So I would start procuring the drug if the patient is not responding to ulinastatin after 48 to 72 hours. I won't wait for 1 week or 5 to 7 days for the drug to act. And if it is not acting in 4 days, we'll get to know that it is not working. So we'll stop it and go ahead with the other monoclonal antibody.
I think that's a very calculated answer. Dr. Ravikumar seems to be having a rich experience of reduction in IL-6 and interleukins by using your regime. Do you have such experience to share with ulinastatin?
Ulinastatin, yes, sir. Because I never experimented with the ulinastatin before when tocilizumab or itolizumab or thymosin alpha was available. As I was saying that this second storm of the COVID, there was a lot of shortage of other drugs. So I had an opportunity to use extensively ulinastatin, and I definitely am happy to share that we saw that there was a gradual reduction in IL-6, not the way the reduction what I used to see with itolizumab, like from 250 to just to drop to 36 or 40 another day. But definitely with ulinastatin, I could appreciate that there was a gradual and a slow reduction in IL-6 levels.
I'm sure it coincided with the patient getting better also, improvement in the patient condition also. We started with Dr. Raghavendra, so we'll end with Dr. Raghavendra. Now, looking at all this experience and what are evidence, the presentations that you and Dr. Ravikumar have done, do you think, Dr. Raghavendra, that just like the Western countries have produced good data with other immunomodulators, since COVID is still raging and we are afraid that the third wave may hit and second wave has not gone away yet, there is a good opportunity for the industry and the medical community to, in COVID, because some COVID patients end up in sepsis also, to do a nice trial and come out with a tangible result.
Yes,
The
sir,
strong evidence Jyoti wanted.
Yes, sir. I think we can come up with some really good evidence because the load of patients which India has seen in the last couple of months, I think the world has never seen. So if we properly conducted trials in each and every institute, I think we can come up with really good data. So how exactly it's working. So coming to my experience using of this immunomodulators, so it completely depends on, as we are in India and like we have a different economical status. So it all depends on the patient's financial status. So initially, when the patient was not affordable for ulinastatin, also I have started using tofacitinib because baricitinib was also not available initially. My wife is a rheumatologist, so it was easily accessible for me. So I started using tofacitinib 5 mg twice a day. So initially, it has shown me some benefits, but it was only used in very limited number of patients. But later on, when coming to ulinastatin, it has shown some promising results, but only in mild cases, mild to moderate cases. But once I see the patients are in severe condition where there's a increase in oxygen requirement, I think ulinastatin has not worked much for me. Then it was a time for me to step up to other monoclonal antibodies. So we have a good experience with tofacitinib and also bevacizumab. So I think tofacitinib has helped me. I agree with Dr. Ravikumar, sir, because like after using tofacitinib, I think there was a very good gradual reduction in interleukins.
Right.
Also, we could see not immediate, but at least we could see a progressive improvement in patients within 24 hours to 48 hours.
Thank you, Dr. Raghavendra. I mean, thank you everyone for such lively discussion and rich experience. When you put together, here we are talking about experience of a team of 5 very young and dynamic intensivists and pulmonologists. So I request Dr. Vijay Chamle to come on video and thank everyone and close the session.
Thank you, Dr. P.V. Gopal sir, for beautifully taking us through the entire session and moderating the discussion. And we'd like to thank all the faculties, Dr. Reddy, Dr. Ravi Kumar, for presenting their two talks very beautifully. And I'm sure that their talk enlightened the delegates on the immunomodulator uses. The panelists, Dr. Jyoti, Dr. Suratwala, and Dr. Barik for sharing their clinical experience during the panel discussion. And it was very heartening for Urihk to organize this webinar under the platform of advocacy for immune modulation in critical illness. As my colleague Surita shared at the start of the program, this is our initiative to ensure that the immunomodulators are used in the right patients in at the right time, and in that pursuance, we are conducting such a program with the help of the eminent clinicians across India. So I like to thank once again each and every faculty delegates for sparing your valuable weekend time for this webinar. And I like to also thank my sales team, my marketing team, technical team for giving the support to organize this program. We at Urihk look forward to organize such meetings in future also. Thank you everyone.
Thank you, Dr. Vijay and Dr. Sunita, for this opportunity, and thank you everyone at Urihk for letting go enriched with some more knowledge and some more courage to use good molecules at the right time. Thank you.
Thank you.
Sure, sir.
Thanks, sir.
Thank you everyone.
Have a
Thank you.
nice
Bye-bye.
weekend, all of you. Thank you.
Bye-bye.
Thank you.